Thank you, Dr. Axman, and thank you for your help in putting this symposium together. And of course, I want to thank the other co-chair, Dr. Tarracone, for coming back from Texas. He doesn't have a Texas drawl yet. I don't know, maybe someday he will, but not yet. He's still got a New York accent. But anyway, also I want to thank Dr. Krishnan and his team at Mount Sinai. They are incredible partners, they are incredible educators, they are incredible doctors, and working together with them, it's incredible. So this is a meeting on wound care as part of an endovascular symposium, which by nature deals with ischemic disease and vascular disease. And most of the talks so far have been talking about wounds in diabetics, or people with peripheral vascular disease. And that is going to be many times, but it's not going to be every time, and that's what we're here to talk about. I have no disclosures for this, and what we want to get out of this talk is to review the various etiologies of pedal ulcerations, discuss the indications for biopsy, and review biopsy techniques. Let's start off with a definition. I think this is kind of rudimentary, but an ulcer is a circumscribed crater-like lesion of the skin or mucous membrane resulting from necrosis that accompanies some inflammatory, infectious, or malignant processes. So everything that happens has a reason behind it. That didn't just fall out of the sky. And we need to not be like the blind men in the elephant, where when you're blinded and you look at, you have no idea what you're looking at. You got to take the blinders off to realize that sometimes there are zebras that occur. Right? Common things are common. Most commonly, a wound on the foot, if not direct trauma related, is going to be either neuropathic or ischemic, but not always. And that's what we need to do, is look at some of the possible explanations for ulcers that could be trauma, moisture infection, impaired blood flow, pressure, neuropathy, neoplasm, inflammatory, temperature extremes. There are a whole host of different things that can occur that we need to think of, and we're going to go through some of these things. In biopsying it also, you also get an impression or knowledge of what the histopathologic basis is, and that can be helpful to you. Is it just inflammatory tissue there? That might lead you into one direction as to what the etiology is, and certainly the treatment of it. Is it infection and inflammation? They overlap. It could be either, it could be or, but all common, there's a combination of an infectious component and an inflammatory. Necrotic disease, necrotic tissue. Again, that will help you determine the etiology and also what needs to be done. Fibrotic tissue versus granular tissue is also, or are also, important considerations. So the approach to the patient with an ulcer is, number one, you need to obtain a history of onset and chronicity. Here's two ulcers. The one on the left hand, I will submit to you, has been present for 30 years. Okay, not much change. And the one on the right-hand side is present for about 3 months. The one on the right-hand side turned out to be an aggressive cancer. And the one on the left was an equine poroma that would have been present for 30 years. But just because something is present for 30 years or 20 years or an extended period of time doesn't mean that there can't be transformation of it. So you want to get a history of it and the chronicity of the ulcer. It's been said many times already, and reiterate, comprehensive medical history. Is the patient diabetic? Do they have known CVD, PAD? Do they have known venous disease, kidney disease? Do they have any autoimmune disease, inflammatory disease, connective tissues disease? What medications are they taking? As Dr. Krishnan said, if you see the list, if someone's taking Synthroid, you know what their problem is. You don't even have to ask them their past medical history. Someone's taking atorvastatin, you know they have high cholesterol. So that'll help you a lot. You want to obtain their social histories and comprehensive. Do they smoke? What's their occupation? Are they on their feet? What about postural positions that they're in? By history, this is a patient who fell asleep on the park bench in Mount Morris Park outside the college on Madison Avenue and decided to spend a nice January night in the park. And this is what happened to him. So just by history, this is frostbite. All right? again, knowing patients aren't always in the great mental state to give you that history that they fell asleep on the bench. So this was a frostbite. This is a diabetic who felt that his feet were cold, and what better way to warm up his feet than to rest them on the radiator overnight or for a little bit of time, and this was by history. Yes, there was neuropathy there. Yes, there's some degree of ischemia there, but the etiology, the direct etiology of this was putting it on the radiator. This is an IV drug user. We used to see these when I was a student all the time, and you know what? We're seeing it more now. There's IV drug use is coming back. Back when I was a student, it was rampant. Then it became the availability pills, the opioids, the pills. Everyone had perks and oxys, and it was all on the street. Now that those have been cleaned up, and it's harder to get that, patients are resulting back to fentanyl and to IV drug use. And we see on the street all the time the little syringes, and we're seeing more and more patients now return to the 70s and 80s. Okay, so chronic wounds, in spite of optimal treatment, may remain in a non-healing trajectory, and this is the time that you need to investigate. You need to think outside the box. Common things are common. This is a post-op bunionectomy that developed an infection. Not a brainer there, but sometimes the type of infection isn't so obvious. Syphilitic infections. These are all real, obviously they're real patients, but who've come into the clinic or to our affiliated hospitals. Syphilitic ulcers, right? It's still out there. Tuberculosis, particularly now with the influx of migrants into the country, coming from medically underserved countries, we're seeing, certainly in the inner city and where these newcomers to the country are congregating, increase in tuberculosis. They're not screened, and so you can have a wound that is tuberculosis. Madura foot on the right-hand side from fungal disease. Vasculitides, right? Small vessel vasculitis in patients with rheumatoid, patients with scleroderma, as you see on the right-hand side there. Again, you need to have the history of the patient and understand that that is having an effect to it. Again, thinking outside of the box. On the left-hand side was a 12-year-old girl who had IBS and a vasculitis associated with IBS, and ended up with that small ulcerations and wounds. We unfortunately had to do amputations of all the toes. And this girl was cute as a button, and she looked up afterwards and she said, you know, it could have been worse. It could have been the whole foot. So, you know, when you're looking at a 12-year-old that does it. In diabetics, pyoderma gangrenosum is also a possibility. In smokers, Berger's disease, thromboangiitis obliterans. Again, history of smoking and small vessel vasculitis and thrombosis at the tip of the toes. Arterial emboli thrown off from patients with endocarditis. It seems, I don't know, I'm just seeing in my patient population more and more patients with AFib these days. I don't know the incidence of it and the prevalence of it. I haven't researched it. It just seems empirically that more and more patients are having AFib. And of course, you pick up any magazine, any newspaper, and you'll see an ad. If you're on AFib, you need to be on, you know, Abaxaban or any of the NOACs, anticoagulant medications. But one of the dangers in AFib is that the fibrillating valves in the heart can result in the formation of thrombus. The big danger is if that clot breaks off, goes north up into the cerebral circulation, that you can get a stroke, but it sometimes can go south. And these are patients that you can see that have a Janeway lesion on the right-hand side, and this is all from thrombotic embolization of a clot generated in the atrium. Okay, so when you see these patients, again, you can see in the on the right-hand side, unfortunately for this patient, it didn't go well. In the bottom side, this is a guy who came in with acute pain in the toe. Didn't have risk factors, wasn't diabetic, had no PAD. The pulse was palpable but irregular. Get an EKG and you see he was an AFib. A little bit more rare, cryoglobulinemia. Seen a couple of patients with this. Casiphylaxis, nephrogenic systemic fibrosis, in patients who were administered dye in taking imaging studies with impaired renal function can end up with NSF. Patients with sickle cell disease can ulcerate. Again, I'm just showing you we can't spend a lot of time on each of these, but there are times you need to think outside of the box. Neoplastic. If you talk to PICA, you talk to MedPro, they will tell you that one of the biggest incidences of med-mal suits is in either the delayed diagnosis or the failure to diagnose neoplasms of the foot. Generates significant amount of med-mal procedures, actions, and the worse the outcome, the worse the case, as it makes sense. On the left hand, a benign lesion, equine paroma. In the middle, verrucous carcinoma. If I told you that that patient was a diabetic and came with that foot, as you've seen many slides today that look similar to that, you say, yeah, that's a diabetic foot ulcer. Okay, in this particular case, it wasn't. That was a verrucous carcinoma. Squamous cell carcinoma on the distal leg can be confused with perhaps with a venous stasis ulceration. Capices. Another thing, we're not seeing quite as much as this, but for a while there, when HIV was rampant and untreatable, we saw lots of patients come in with Kaposi sarcoma in the foot. This is a patient who had this lesion that you saw here, 56-year-old, non-diabetic, palpable soft tissue mass. She had 2 separate biopsies. One of them, she even went to Sloan Kettering. And they said, I got this lesion. And so none of us could figure out what was going on here. One day she came in and says, you know what, doc, I figured it out myself. I pulled a staple. She had stepped on a staple. And that was an inflammatory foreign body granuloma that was there. This patient, pre-diabetic, non-healing wounds, 6 weeks, pre-diabetic. Put 2 and 2 together, you say, well, it's a diabetic ulceration. But in this particular case, you put 2 and 2 together, you're going to get 5. Right? What this was a melanoma. You can see some pigment over here, but this was, for the most part, a melanotic melanoma. So everything has a reason. If the treatment that you prescribe fits your diagnosis but doesn't work, it's time to reassess what the diagnosis is and what the treatment plan that you did. Chronic wounds and malignancy, well, it could be a primary cancer. You ask, how could this patient actually walked into the emergency room at Metropolitan Hospital, had this lesion on his foot for several months. You ask, how could that happen? But it does. So primary cancers, wounds degenerating into cancer. This, in fact, was a diabetic who was treated for a DFU, whether it was primarily a squamous cell carcinoma or whether this was a wound that degenerated into a squamous cell carcinoma, we don't know, and you'll never know. The fact of the matter is that this was treated inappropriately as a DFU for several months until such time that it looked like it did on the right-hand side. Patient sought second opinion. By that time, this is actually metastasized to the lungs. The patient expired, and as you would guess, generated a fairly significant med-mal. This is a patient treated as a wart for 14 months. Sal acid and cantharone and all kinds of lotions and potions on it. This also turned out to be a squamous cell carcinoma. Systemic malignancies with skin infiltrates. These are usually the blood-borne tumors. The lymphomas, round cell tumors, blood tumors can have dermal manifestations, as this patient here had lymphoma. And with the novel agents that are being utilized to treat malignancies, many times these not chemotherapy, these immuno agents, they're very good at curing or managing the cancer, but they do have many times dermatologic and neurologic side effects. And some of these, particularly in the foot and hand-foot syndrome, are a result of the medications that are used to manage. So when do you biopsy an ulcer? Looks suspicious, uncertain diagnosis. You can't explain it by neuropathy or ischemia. It continues to heal in spite of good wound care, an unusual anatomic site. It's causing pain, or certainly if you see pigmentation. To diagnose, why do it? To diagnose, rule out malignancy, obtain culture, CNS. Contraindications would be blood dyscrasias with an increased bleeding risk. venous congestion, or if you feel that there is severe arterial insufficiency, they might want to get management of the PAD before you're going to do it. A venous malformation like you see on this particular, on the right-hand side there, you cut into that and biopsy it, you're going to have blood on the ceiling. So you need to work with the vascular people in advance of it. General considerations: what type of anesthesia, what type of antiseptics you're going to use, topical antibiotics, need for prophylactic antibiotics. The protocol is generally you want to orient the incision so the tract can be excised en bloc. Should it turn out to be something bad and you need a major definitive procedure. In other words, you do not want to violate other compartments. You need to obtain adequate tissue. Tourniquet use, I do it, although some people frown on that because they feel when the tourniquet comes on that there's this tidal wave of blood that will come through, and if indeed there was a malignancy, that it could dislodge malignant cells, but many people still do. Frozen section, I'm getting less of them now because I'm relying on the final biopsy result. Frozen sections, if you're in the operating room and you're kind of sure it's benign but want to make sure, and just to confirm it, that might be the time to get a frozen section. Shave biopsies obtains only epidermis and superficial dermis for exophytic type lesions. But remember, if you're just shaving, you need to get down depth, and many times a sorcerization or a scoop technique is preferable to get the full depth of the lesion. If you're taking punch biopsies, this was treated as a DFU for any number of months. You can see the old days gentian violet put on there. You want to take multiple punches in representative areas. You send each one separate and you label it individually, because when you get back the separate locations, you can see that the histopathology in these different locations was very different. And if you just did area C and didn't biopsy the other areas, you would come away thinking that this is just a keratotic lesion and not, in fact, the melanoma that it was. Excisional biopsies, again, we try to, well, if it's a large lesion that's going to need a plastic surgery closure or plastic surgical closure, I'm generally looking to get the definitive diagnosis before planning out the specific procedure. The transport media, you have to be careful what it is you're looking for. We all know if you're looking at gout, you want to put in alcohol and not formalin. The information that you want to provide to the pathologist is the standard demographic. And the path report that you get back these days is not your father's pathology report. It's not going to be just the H&C and looking at the architecture of it. There's going to be all sorts of antibody tests. There's going to be all different skin markers, which will help specify what the specific diagnosis is, and more importantly, how to do it. Manage and develop a treatment plan. Genetic expression profiles are common in cancer therapy. If it is a malignancy, that helps map out the treatment plan. And with that, only 26 seconds over, and I like that the doctor will be with you tomorrow, as he believes time heals all wounds. Thank you very much for your time. Thank you for being here.